The following podcast is part of a certified educational activity, Rethinking Glioblastoma Care in an Evolving Therapeutic Landscape. Expert perspectives on modern modalities, novel agents, and combinations. Featuring Stephen Brem, MD from the Perelman School of Medicine at the University of Pennsylvania in Philadelphia, Pennsylvania. Manmeet Ahluwalia, MD, FACP, MBA from Burkhart Brain Tumor and Neuro-Oncology Center, Cleveland Clinic in Cleveland, Ohio. And Stephen A. Toms, MD, MPH, FAANS, FACS, from the LPG Neurosurgery Norman Prince Neuroscience Institute in Providence, Rhode Island. Access the entire activity and complete the post-test at peerview.com/CBA860. Downloadable slides and practice aids are also available. Thank you for listening to PeerView Podcasts. We greatly appreciate your support and would like to hear from you. Can we ask for a favor? Participate today in a short 1-minute survey at www.peerview.com/podcast survey to share how podcasts play a role in your medical education routine. Again, that's www.peerview.com/podcast survey to participate. And now, on to today's podcast.
Thank you. Welcome to Rethinking Glioblastoma Care, an evolving therapeutic landscape. And we're going to have expert perspectives today on modern modalities, novel agents, and combinations. I'm Dr. Stephen Brem from the University of Pennsylvania in Philadelphia, and I'm pleased to welcome my colleagues, Dr. Manmeet Ahluwalia from the Burkhart Brain Tumor and Neuro-Oncology Center, Cleveland Clinic in Ohio, and Dr. Stephen Toms from LPG Neurosurgery, the Norman Prince Neuroscience Institute in Providence, Rhode Island. So it's my pleasure to begin and review some of the basics of care for glioblastoma. And our first slide, as many of you know, glioblastoma is the most common and aggressive glial tumor in adult patients. Its onset is linked to age, most common after age of 60. Biology is linked to cellular senescence, such as senescence-associated genes, and the prognosis is correlated with age. And the prognosis for 5-year survival remains less than 5%. MRI findings show a T1 hypointense and a T2 increased signal in the edema infiltrative zone. There's T1 in a ring of enhancement and irregular borders, mass effect, and an invasive phenotype. For example, the butterfly glioblastoma invading the corpus callosum. Our goals, we have to think of the tumor in two compartments. There's local regional control, which is affected by surgery, radiation therapy, stereotactic radiosurgery, and tumor treating fields. That will be the center. And systemic control, and that's why we go to chemotherapy, biological therapy, immunotherapies, and targeted tumor therapies. So our agenda today is Dr. Toms will discuss how to optimize tumor treating fields in the management of patients with glioblastoma, and Dr. Ahluwalia will explore new and novel systemic treatment options for patients with glioblastoma multiforme. We'll also be sharing a patient story and highlight the support that the American Brain Tumor Association provides to our patients. So now it's a pleasure to turn the podium over to Dr. Stephen Toms.
Thank you, Dr. Brem. I appreciate the introduction, and welcome everyone for joining us this evening. Today I'll be talking about effectively integrating modern modalities in the management of glioblastoma. Now, the NCCN has recommended treatment approaches in both newly diagnosed and recurrent glioblastoma. For those who are newly diagnosed and less than 70 years of age, we always consider clinical trials for patients, standard radiotherapy with concurrent temozolomide and adjuvant temozolomide, and tumor treating field therapy is a Category 1 recommendation for treatment of these patients. Standard brain radiotherapy, temozolomide may occur afterwards or as an adjunct is another Category 1. For patients who are unmethylated, however, sometimes we choose to avoid the temozolomide and can look at radiation therapy alone, as the temozolomide is a little less effective in this group, as we all know. Now, in newly or recurrent, in newly diagnosed glioblastoma who are older than 70 years of age, the treatment paradigms can vary a little bit in that we sometimes consider hypofractionated radiotherapy with or without radiation. In the methylated group, obviously, we use the temozolomide if we believe the patient can tolerate it, whereas in the unmethylated group, using the temozolomide is somewhat discouraged, especially in this older group. And when we talk about tumor treating fields, we're talking about a novel type of anti-mitotic therapy. And this was initially thought of because there are many charged molecules in the body, including molecules such as tubulins and septins, which are involved in attaching to and helping the chromosomes pull apart during the M phase of mitosis. Charged particles and dipoles, such as those in these charged proteins, can be influenced by the electrical fields, and what tumor treating fields are alternating electrical fields that seem to be able to disrupt these charged particles during mitosis, which may lead to cell death, it may lead to cell cycle arrest, and appears to spare quiescent cells. Now we'll take a look at a video that describes the mechanism of action of tumor.
In metaphase of cell division, cells are a rounded shape as the mitotic spindle forms. Intracellular components such as macromolecules and organelles are naturally charged. Tumor-treating fields, or TT fields, disrupt cancer cell division by physically interacting with molecules required for mitosis. When alternating electric fields are applied to cancer cells, they disrupt microtubule polymerization. Tubulin dimers align with the electric field and are not able to form microtubules. This prevents the organized assembly of the mitotic spindle required for normal cell division. The inhibition of microtubule formation leads to metaphase arrest and cancer cell death. In addition, these deformed microtubules can lead to abnormal DNA segregation between daughter cells, which also results in cancer cell death. TT fields can also affect cells after metaphase. If a cancer cell has passed metaphase and enters the cytokinesis phase, the cell takes on an hourglass shape. This state under TT fields creates a non-uniform electric field inside the cell, creating dielectrophoresis. Net forces push the macromolecules and organelles toward the mitotic furrow, and this disruption leads to structural disorganization and cancer cell death.
Now, hopefully that video gave a little idea, in cartoon form of course, of how tumor treating fields can work on the chromosomes and mitosis in the cell, and how it may lead to cell death. Now, one of the important things to understand about tumor treating fields is that, at least in vitro, there's evidence that the mechanism of action of tumor treating fields is somewhat cell size dependent. Larger cells, such as normal intestinal epithelial cells, are only affected by tumor treating fields around 50 kilohertz, whereas cancer cells tend to be a little bit smaller, ranging from larger cells such as breast cancer, which responds at about 120 kilohertz tumor treating fields, pancreatic and mesothelioma about 150 kilohertz, and then once we get to glioblastoma, we're looking at a 200 kilohertz field. The smallest of the cells, like small cell carcinoma of the lung, respond to an even higher field of about 240 kilohertz. So in order to deliver this to a patient, we're looking at a mechanism where we give a non-invasive device that provides the localized treatment with the tumor treating fields. As we see in the model on the right, 4 electrodes, each of which are about the size of the palm, and deliver current through 9 ceramic electrodes in the array that is placed on the head, deliver low intensity, about 1 to 3 volts per centimeter squared, of intermediate frequency, 200 kilohertz for glioblastoma, alternating electrical fields. And they go from the anterior-posterior direction to the medial-lateral direction. They alternate about every second. These transducer arrays are applied by the patient, have to be changed every 2 or 3 days. And the placement of these arrays and transducers is individualized for each patient. Now, the way in which these are individualized is maps are made through a proprietary software from the company that takes MRI data and localizes where these fields are to be placed. A map is generated for each patient that shows the patients and their caregivers how to apply the tumor treating field transducer arrays. And we have to remember that with tumor treating fields, we're looking at a relatively long wavelength. Many of our audience might be used to doing stereotactic radiosurgery, where we have very tight fields by which we deliver and a rapid fall off of how that treatment is delivered, whereas tumor treating fields, we can move these electrodes a few centimeters at a time and not markedly change the dose in our patients. Now I'd like to talk about the EF14 trial. As many of you may remember, the EF14 trial was the trial that looked at adding tumor treating fields for newly diagnosed glioblastoma. And the scheme of this study was looking at giving tumor treating fields plus or minus standard of care, which is daily temozolomide during radiation therapy, along with adjuvant temozolomide monthly for at least 6 months following the radiation therapy. Tumor treating fields were applied at the start at approximately 3.5 to 4 months after surgical resection, about 1 month after the end of radiation, and were tried to be given daily for at least 75% compliance, meaning the tumor treating fields were turned on at least 18 hours per day on average. Tumor treating fields were given up until the second progression or up to 24 months during this protocol. The protocol was stratified for extent of resection, which we know impacts survival, as well as MGMT methylation status. IDH1 status was not stratified in this study as it started about 14 years ago. Now, when we look at the overall survival in the intent to treat population, we noticed that folks who were treated with the standard protocol, that getting daily temozolomide plus temozolomide and radiotherapy followed by monthly temozolomide, the median survival after randomization was 16 months, where it was 20.9 months in those who were treated with tumor treating fields in addition. 2-year survival was increased at 43% in the tumor treating fields plus temozolomide versus only 30.7% in the temozolomide alone group. And if you look at the overall survival from diagnosis, it was a little bit over 2 years in the tumor treating fields group versus 19.8 months in the temozolomide alone group. And although this survival curve is not marked, it is about the same amount of increase in survival we had with the original Stupp protocol from the 2005 New England Journal paper that added several months of survival. Now, as we look at the subgroup analysis of the data from the EF14 trial, not surprisingly, we find that methylation status is very important, as it is in many of our studies. In our unmethylated group, we increased survival only about 2.2 months, from 14.7 to 16.9 months with the addition of tumor treating fields. But in our methylated group, we add over 10 months of survival, going from 21.2 to 31.6 months. This, like in many of our therapies, suggests that as we get more and more effective therapies against glioblastoma, that the methylated group is going to perform even better because we can take the number of cancer cells down to a lower level, and each additional therapy seems to add more and more to this group. Our unmethylated group remains relatively refractory to our therapy at this point. And as a surgeon, I have to say the other disappointing part of this slide is that surgeons become less and less important. In other words, our extent of resection becomes less important as we get more therapies. In biopsy alone, tumor treating fields added 5 months of survival, whereas when you get a near gross total resection, it was only adding about 3 months of survival. So as we improve our therapies, we may find that folks like myself and Dr. Brem become somewhat less important and become diagnosticians instead of tumor debulkers and real cancer surgeons. Now, when we look at how tumor treating fields impact the general functional status and quality of life of our patients, we find that there was really very little impact. For many of our oncologists, we understand that when do our patients decline? When tumor progresses is when we usually see decline. So when we look at general functional status and quality of life in our patients, tumor progression has more of an impact than our therapies. And fortunately, we found that tumor treating fields were generally well tolerated with very few side effects that impacted quality of life. As many of us know, and we'll talk about a little later, dermatologic problems tend to be our biggest problems with tumor treating fields. Now, when we did some further look at the EF14 study and some post hoc analyses, one of the first things we did was look back at the 695 patients and started to stratify them into compliance, since with tumor treating fields we were able to get data in all of our patients on how effectively they were wearing the device. And what we find is that patients who are wearing the device less than 50% of the time, less than 12 hours a day, really had very little impact on their survival. And we only started to see some impact on survival when they started increasing past 12 hours per day. Interestingly, as we really pushed into the Interestingly, as we really pushed the compliance and got people who were wearing it 80 and even 90% of the time, 21 or 22 hours per day, our median survivals began to increase even further from the 20.9 months we saw on our greater than 75% up to over 24 months in those who were wearing the device greater than 90% of the time. And when we look at the compliance in that highest group who are wearing it greater than 90%, we see a relatively interesting phenomena in that we lose patients through year 1, 2, and 3, but then we seem to plateau at about 29.3% of our patients who are surviving year 3, 4, 5, and beyond. And I certainly saw some of this in my own patient group, and I actually have 2 patients who are over 10 years survival now from this study who were highly compliant with their wearing of their tumor treating fields. It does suggest somewhat, and we see some of this in some immunologic studies, that we have a long tail of people, and there has been some suggestion that tumor treating fields may not only be an anti-mitotic therapy, but by causing cellular apoptosis and perhaps blebbing of neoantigens, that we do get somewhat of an immune response, although this mechanism of tumor treating field effect certainly has not been sorted out at this point. An additional post hoc analysis we did of the patients in the EF14 trial looked at dose intensity and the power density associated with overall survival. Now, what does this mean? In order to do this analysis, we did a finite element analysis of how the tumor treating field electrical current was expected to flow through the brain, made maps onto the MRIs, and then compared this to see where we thought the current was flowing, map that out versus the MRI to see if we could see what dose level we were getting. Because there has certainly been some data in cell cultures that doses over 1 millivolt per centimeter increase the tumor kill. And in fact, when we went back and segregated about 350 patients who were eligible, that we had MRI data and could do the finite element analysis on, we found that those who were treated with over 1 volt per centimeter did have a better survival by a few months over those who were treated with large amount of their tumors outside that 1 volt per centimeter squared. Per centimeter, excuse me. When we add compliance into it, or dose density as it's sometimes called, which is a combination of the dose intensity plus the compliance, we see that those who got higher dose by that combination also did a little bit better. And this was even a bit more statistically significant than looking at dose intensity alone. Now, this slide's a little bit busy, but if you stare into it and don't get lost in all the overlapping curves, what you find is a shift to the up and the right. In other words, longer survivors on these curves who are getting higher doses and higher compliance. And this meant that higher tumor treating field intensity, again, greater than 1 volt per centimeter, and higher power density, greater than 1.1 milliwatt per centimeter cubed, again, a combination of that dose intensity plus compliance, were associated with increasing survival. Now, you can visualize this on MRIs using finite element analysis of where the dose was flowing. But the important takeaway from this is that if we are get our patients to comply more, in other words, wear their device more frequently, and we're able to map out our dose intensity well over where the tumors are, In other words, we have our smallest volume of tumor and we're able to get good dose in that area of the brain, we can get better results with this. Now, one of the ways you can think about getting better compliance is a little phenomena I noticed with our patients who were on trial, is that they're getting report outs from the company and from the device about how often they're wearing it. And they get a readout as to whether they wore it 70% for the month, 80% or more. And I found that our patients actually became competitive with one another and asking about how they were scoring on their compliance and how they were doing versus one another. And if you have your patients comparing that data a little bit in their tumor support groups, you'll find a little bit better compliance in the group as they start to compete with each other and let each other know that they're expecting them to be compliant, that they're their support, they're their buddies, and they want to see high compliance. And I think that's why many of my patients, honestly, did a little bit better than the mean in the study as published. Now here's a couple of MRIs to show you how this finite element analysis of this worked. So at the top left-hand corner, we see a baseline MRI of a patient with some residual tumor in the left parietal occipital zone. The top is the baseline MRI, the bottom shows the progression. And when we do this finite element analysis to show where the tumor treating fields were flowing is mapped out on the slides on the right. We see that the highest segmentation volumes where you have the gross tumor volume in the red, the resection cavity in the cyan, and the 3 millimeter line around the baseline in yellow, that's where we were hoping to get the tumor treating fields and where the tumor treating field intensity was the highest. This was all over 1 volt per centimeter. Now the tumor did progress, and when we look at that in the bottom right corner of the MRI on that map, the tumor progressed outside that 1 volt per centimeter area. And in fact, if you looked at that, the dose of the tumor treating fields were a little lower, and we did have progression outside there. Now, most of us know with glioblastoma that the most common area for progression is within a margin of the resection cavity, usually within 1 centimeter to 2 or 3. When you see tumor treating fields in good dosimetry over that, you will somewhat more often see more distant recurrences, and I started to see distant recurrences either within or even in the contralateral hemisphere on those who were highly compliant using their tumor treating fields. And my failure patterns were a little bit more distant than they had been without tumor treating fields. Again, suggesting that tumor treating fields is mostly a local therapy, even though it does have some treatment effect over larger areas of the brain. Once again, if we look at this on this color map here, on the left-hand side you have an MRI with the outline of where the tumor treating field doses were the highest. On the right-hand side you have a pseudo-colorized map of where tumor treating fields were in their highest intensity, with the highest intensities being in the yellow, medium intensities in the red, lowest intensities in the blue colors. Where the area of progression was, you notice, was an area of red, so it only had medium field intensity. And if we looked at the 197 patients that were analyzed at this in the study as this was presented, the mean dose intensity at areas where tumor regressed was about 0.83 milliwatts per centimeter cube, and the dose density in areas of progression was a bit lower at 0.71 milliwatts per centimeter cube. What does all this suggest? That we need to be careful about our mapping, number one. And if we see in our tumor treating field planning that we've got areas that are outside, or if someone's MRI shows progression, we may need to go back and remap and perhaps move where the electrodes are. And number two, that down the road, if there are ways that we can increase the dose, and this may require some engineering down the road on parts of the company and others who are using tumor treating fields so that we can get higher doses, we may be able to get better tumor control. But all this remains to be seen as we continue to progress in this mode of therapy. Next, we're going to look at an older study. This was a post-hoc study after compliance called the EF19 study, after FDA approval of tumor treating fields in recurrent glioblastoma. When tumor treating fields were used as monotherapy in recurrent glioblastoma, this compared tumor treating fields alone versus best standard of practice for recurrent glioblastoma. And that included things such as lomustine or bevacizumab. We did notice that there was, in clinical practice, a somewhat improved survival in those who got tumor treating fields as monotherapy versus best chemotherapy standard of practice. The effect was not large, but one of the important things was that it had a little bit better survival and much fewer adverse effects than compared with chemotherapy. So it certainly suggests that even in our recurrent patients, tumor treating field monotherapy can be a useful adjunct. Now, there are several new studies coming out, new strategies to use tumor treating fields. A new study called the Phase 3 Trident study will be opening nationally shortly and may be opening at an institution near you. What this is going to do is looking at using tumor treating fields along with radiation therapy and temozolomide, but moving back the start of tumor treating fields during radiotherapy versus tumor treating fields started at the standard time after radiotherapy has completed and about a month after radiotherapy has been completed at the start of adjuvant temozolomide. The study should be opening soon. Hopefully we'll have reports on that in the next 2 to 3 years as we start to enroll. In addition, there's a Phase 2 trial looking at tumor treating fields with radiosurgery plus for recurrent bevacizumab-naive glioblastoma with a primary endpoint of overall survival. That stereotactic radiosurgery has to be after 6 months after the radiotherapy had been performed initially. There was a Phase 2 trial looking at tumor treating fields with bevacizumab in which 25 patients were enrolled. Not surprisingly, most of the patients were male, as still getting tumor treating fields to female patients has been a little more difficult, thanks in no small part to the head shave that has to go along, and a lot of male patients are already there biologically by the time it's time to look at using this therapy. Median progression-free survival using tumor treating fields with bevacizumab was about 4.1 months, and progression-free survival at 6 months was 33%. Overall survival in this trial was 10.5 months, and overall survival rate at 6 months was 82%. Grade 3 and 4 toxicities were relatively uncommon and were stroke and hypertension, more likely related to the bevacizumab than the tumor treating fields themselves. A couple of things to note during the era of COVID-19 is that the tumor treating fields can be started with patients and their families using no contact techniques. There are communication measures that have been put together to allow patients to communicate with the providers and with the technicians who help with tumor treating fields. And to date, they've had no trouble with getting starts and getting good patient compliance with this. No new safety signals have been seen during this new approach to starting, and it does look like we are able to start tumor treating fields effectively using telemedicine and no-touch techniques. And thus far, tumor treating fields have no known immunosuppressive effects during the COVID-19 era, and we again seem to have a good safety profile using this technique. So there are a few abstracts that were presented at SNO 2020 that related to tumor treating fields, including scalp-sparing radiation therapy with concurrent temozolomide and tumor treating fields, using tumor treating fields for recurrent glioblastoma with targeted skull remodeling surgery for those who have had problems with infection and needed post-op skull remodeling surgery, as well as an abstract looking at the comparison of symptom burden and associated impact on daily life in patients with glioblastoma and tumor treating fields. So I hope you got a chance to look at those during SNO 2020. Next, we'd like to talk about some of the side effects you can get with tumor treating fields. As most of us know, most of these are dermatologic. Hyperhidrosis can be a problem, especially during the summer in the south and in a warm environment. There's some topical aluminum chloride products that can be used to help, and obviously getting people out of the hot sun when they're wearing the device can help somewhat. Pruritus or itching skin can be a problem. Sometimes topical corticosteroids are necessary or treatment with antihistamines. But the biggest problem we tend to see, especially in post-surgical wounds, are ulcers or erosions related to the electrodes themselves. Occasionally, they can break down enough to cause a secondary infection, must be managed with either topical or oral antibiotics, but the most common thing are getting little ulcers or sores that may be managed by moving the arrays slightly so that the ceramic electrodes are not always in the same place, especially if the scalp is thin or over an area that has a titanium plate underneath that's holding the bone in place, and sometimes topical corticosteroids may be used. So other things that can be done to help out with patients is giving short breaks from tumor treating fields to allow the scalp to heal just a bit. So in conclusion, we can say that tumor treating fields are an alternating electrical field that can disrupt or interfere mitosis, potentially leading to cell cycle arrest or cell death. That tumor treating fields are an option for both methylated and unmethylated patients in either recurrent or newly diagnosed glioblastoma. We've noted that the survival benefit is most marked in patients with methylated MGMT, and then those whose dose density, and that's both power intensity and compliance, is high, and that most of the adverse effects associated with tumor treating fields are dermatologic in nature and may be managed with simple treatment paradigms. I want to thank you for your time, and we'll be prepared for any questions.
It looks like we have some questions that have come in. First, how do you educate your patients on tumor treating fields? And the second one is any advice on how to work effectively with the entire multidisciplinary team when a patient is being treated with tumor treating fields. So would either of you like to start? Maybe Dr. Toms first?
Thanks, Dr. Brem. Like you, I'm a surgeon, so I'm often one of the first contacts a patient with glioblastoma meets. And early in the education of the patient, often preoperatively, I do mention that there is a newer modality available for treatment of glioblastoma that's been getting some prolonged survival in many of my patients. So I introduce the concept of tumor treating fields early, and then as we segue into that second question, really it's important to have the entire multidisciplinary team bought in and be on message in order to get patients interested in complying with and using tumor treating fields. I find it important to discuss at our multidisciplinary tumor conferences and our multidisciplinary clinics that we often mention this. And we have to have similar messaging coming from our radiation oncologist, our medical and neuro-oncologist, to our patients that tumor treating fields are an effective therapy and have relatively few side effects. So, Dr. Alajuela, do you find something similar in your practice?
So I agree completely with Dr. Tom's. Management of patients with glioblastoma is a multidisciplinary sport. So if we have the same messaging coming from neurosurgeons, radiation oncologists, and medical neuro-oncologists about the value of treatments that we offer to our patients, it has a better impact. So with tumor treating fields, if a neurosurgeon mentions that after surgery or before the patient meets with a medical and radiation oncologist, it's always helpful because they've heard it from someone. We also have mannequins that we have in our physician workrooms. We take it to the patient, we show it to them, and there's also a buddy program where we offer patients can speak to someone else. So I think when the patients hear this from different people, it just helps them get a better sense of this new modality and what it can do for them. And additionally, when patients hear about that they can actually actively play a role in their own management, I think it's extremely well received by a number of our patients and their families because they want to contribute to their own care.
That's great. And now we have heard from the experts, but real expert is the patient. And we have an extraordinary patient who presented her story at the 2020 American Brain Tumor Alumni Research Network meeting. Her name is Jinan, and she was very accomplished. Before she had a glioblastoma, she was in the top 10% of her at law school at Boston University. Had many other accolades, and one day she had migraine and headaches, and the tumor ultimately was diagnosed, underwent surgery, diagnosed as a high-grade glioblastoma, and underwent the usual treatment with chemotherapy and temozolomide, and then 40 days later started tumor treating fields. So it's been now 2 years, and she's become very involved with ABTA. So let's hear from Jinan in this short clip when she presented
As time went on, my outlook changed. I started to see the blessings that this otherwise horrific experience brought. Many people, even ones I have never met, have showered me with prayers and encouragement. I've also been able to help others with GBM diagnoses. I've spent more time with my family. I've learned to value the beauty in small things, seeing a niece win an ice skating competition, watching a little nephew light up with joy upon seeing his birthday cake, and giving a teen nephew advice on how to approach his first crush. And I just need to thank you all for the work that you do for patients like me to give me those days where I was able to see that. So even though I'm in tears, I can say today that I am happy and I embrace my reality instead of denying it. I'm comfortable answering questions about my diagnosis, and with my doctor's permission, I'm actually working again. I'm not traveling now because of Corona, but I have traveled to visit friends and family. Mom and I went on a cruise to Alaska last year. And while fighting GBM, I was able to speak at my grandfather's funeral. I've taught at several nonprofit conferences. I help homeschool my nieces and nephews, and I even spoke at a press conference in front of the U.S. Supreme Court. I take pride that with the support of my friends, family, physicians, and the researchers, I am beating GBM. I look forward to many more joyous years of being with family and doing the work I love and serving others. In the words of Eric Little, my calamity has been used victoriously to work out a wonderful plan of love.
That was very moving, and we wish her and her family well. And now we're going to move on to the future, the bright outlook for novel systemic options. And it's a delight to introduce again Dr. Mamit Ahluwalia from the Cleveland Clinic, who's going to discuss novel systemic options for patients with glioblastoma.
Thank you, Dr. Brem, for the kind invitation to come and talk about novel systemic options for patients with glioblastoma. Dr. Toms gave a very eloquent, comprehensive talk, and Steve is always a tough act to follow, but I'll try my best. Glioblastoma is one of the most vascular tumors that we know, and hence angiogenesis remains a very attractive therapeutic target in glioblastoma. There have been a number of approaches that have targeted various aspects of this pathway, targeting vascular endothelial growth factor, targeting platelet-derived growth factor, or fibroblast growth factor. This is the NCCN guidelines that look at various treatment options for glioblastoma, and Dr. Toms very eloquently covered the upfront and the adjuvant treatment for glioblastoma that includes radiations with concurrent and adjuvant temozolomide, along with the treatment option of tumor treating fields. Unfortunately, most of our patients, despite this, recur. And when they have a recurrence of glioblastoma, there are a number of treatment options for them, which are the preferred regimens as per the NCCN, that include a number of approaches that actually target angiogenesis, namely bevacizumab, which is a monoclonal antibody against vascular endothelial growth factor, or Regraphenib, which is a multikinase tyrosine kinase inhibitor. There are a number of other approaches which are alkylating agents that include a rechallenge with temozolomide, or using lomustine or carmustine, or the combination of procarbazine, lomustine, and vincristine. So what's the data for use of bevacizumab? So this is the phase 3 trial that looked at bevacizumab plus lomustine, compared this to lomustine. This was a study that was done under the auspices of EORTC and led to a New England Journal of publication a few years back, led by Dr. Wolfgangwick. Here, patients, after they had progressed with chemoradiation, were randomized 2:1 to bevacizumab along with lomustine, comparing that to lomustine. Lomustine has become pretty much the drug of choice in recurrence against which most therapies are compared. And as you can see in the curves here, pretty much overlapping curves with use of lomustine plus bevacizumab that was not statistically significantly better in increasing overall survival as compared to lomustine alone. Despite this, bevacizumab received full approval by FDA for use in recurrent glioblastoma, showing the dearth of therapies and the active and urgent need for new treatment modalities for these patients. So what's the data for Regraphenib? So this was the Regoma study. This was again a study done in Europe where patients who had recurrent glioblastoma after undergoing radiation and temozolomide were randomized 1:1 to either receive Regraphenib, which is a multikinase tyrosine kinase inhibitor that targets VEGF, and a number of other targets that include CSF1R. And here Regraphenib was given at doses of 160 milligrams per day, 3 weeks on, 1 week off. And this was compared to lomustine that was given at a standard dose of 110 milligrams per meter square on day 1 every 6 weeks. The primary endpoint of the study was overall survival. As you can see, this is a fairly busy slide with patient characteristics. 59 patients received Regraphenib, 60 patients received lomustine. And as you can see, between age, sex, performance status, surgery, steroids, molecular markers like IDH and MGMT status, they were fairly well balanced between the two arms. So what was the efficacy analysis? As you can see on the left side, we see overall survival with Regraphenib in the blue curves and lomustine in the orange curves. And as you can see, there was an improvement with use of Regraphenib, where median overall survival was 7.4 months compared to lomustine, which was 5.6 months, leading to an impressive hazard ratio of 0.5. Now, obviously, interesting thing to compare is when we look at other studies, the outcomes of this trial are a little bit less numerically as what we've been used to seeing. Nevertheless, this was a randomized trial with a very increasingly intriguing hazard ratio, something that is being explored in a larger trial that I'll talk to you about in further slides. But what was also interesting looking at the progression-free survival, as you can see on the right side of the curve, there was a very quick drop-off in almost the median number of patients, both with Regraphenib and lomustine. However, after that, we can see a number of patients with Regraphenib who got a benefit as compared to lomustine, which led to this tail seen in the overall survival, almost 25% of patients getting benefit even a year and a half out, something that is not very common in recurrent glioblastoma, pointing to maybe a immunotherapy kind of effect of this drug. And we do know that this drug does target CSF1R. So hence, very intriguing data. Now, looking at the response rates, as you can see, very comparable response rates with both Regraphenib with 5% overall response rate, along with lomustine, which was 3%. This is very comparable to what we've seen in other trials. But what was very interesting also in the study was, as we saw, a number of patients got durable control of their disease with Regraphenib. So overall disease control rate was 44% with Regraphenib compared to 20% with lomustine. Then we look at the forest plot curves, looking at what are the subset groups that are getting benefit. So if you see more of the curves on the left side that favor Regraphenib, if you see things on the right side, they favor lomustine. As you can see, younger patients less than 65 years of age derive greater benefit from Regraphenib. If females tend to derive greater benefit from Regraphenib, although males got a good amount of benefit from Regraphenib as well. If you had no surgery at relapse, you got greater benefit. Those patients who were methylated tend to get more benefit from Regraphenib. This is very intriguing because we know lomustine is an alkylating agent, and patients who have MGMT methylated status tend to get benefit more from drugs like lomustine. And here you can see clearly a hazard ratio of 0.43 favoring Regraphenib over lomustine. Again, those patients who were not on steroids tend to get greater benefit from Regraphenib, again alluding to maybe an immune component of this therapy. And patients who had a good performance status, ECOG was 0, tend to get more benefit from Regraphenib as compared to lomustine. Then obviously when we give therapies to our patients, not only are we concerned about the efficacy, which is obviously of major interest to patients, but we are also concerned about the safety or the toxicity profile. So this is a fairly busy slide looking at the toxicity of these two regimens. Lomustine is an alkylating agent. As a result, you can clearly see there was thrombocytopenia. That means the platelet counts were decreased, and there was neutropenia. That means the white blood count and the neutrophil counts decreased with use of lomustine. On the other hand, with the use of Regraphenib, the counts were not much altered. However, we saw an increase in the lipase in a number of patients. And what was also very interesting, which is there was an increase in the hand-foot skin reaction. So this is a reaction which is seen often in patients who are treated with other tyrosine kinase inhibitors as well, like sorafenib, sunitinib, drugs that are used in kidney cancer, as well as drugs like capecitabine, which are drugs that are used in breast cancer. So here we can see almost 10% of patients had grade 3 hand and foot skin reaction. But if you keep an eye and are more aggressive in managing this, we have seen better control of this in our patients. And we have a investigator-initiated trial looking at Regraphenib in patients with recurrent glioblastoma at Cleveland Clinic, where we actively actually educate the patient about this particular side effect that can occur with this therapy. So what we know is that glioblastoma is a difficult to treat disease, and hence enrollment of patients in clinical trials is of paramount importance. And number of our patient education, patient support groups, groups like NBTS, ABTA, have really partnered up with academic and community hospitals trying to increase their education for increasing clinical trial enrollment. However, despite this, less than 15% of patients with glioblastoma enroll in clinical trials, something we can definitely all work cohesively together and improve. Because we know we need to improve the patient's access to clinical trials, make criteria less restrictive, make new agents that tend to fail in recurrent setting and then are abandoned. We need to work together to find the best treatment options for our patients. So how are we doing this? There are a number of large platform studies which are going on, and I would like to start off with the one which is one of the largest ones, that is the GBM Agile. This is a multi-institution, multi-continent effort looking at adaptive phase 2-3 clinical trial design in patients with both newly diagnosed and recurrent glioblastoma. So you can have a drug. Right now, Regraphenib is actually the first experimental drug that is being evaluated under this trial mechanism. Here you can have a Regraphenib being looked at in both in a front setting, and at the same time it can be looked at in recurrent setting. And there are a number of other drugs like Paxlovid and Val-083, which are also going to be tested under this platform and trial mechanism. So please, if you have patients, encourage trial participation in platforms like this. On the other hand, also Dr. Toms had alluded to that patients with unmethylated MGMT with glioblastoma get marginal benefit from temozolomide. So this is the Insight platform looking particularly at patients with newly diagnosed glioblastoma, only those who have unmethylated MGMT. And here there's a common control group which everyone gets radiation and temozolomide followed by adjuvant temozolomide, but we have a number of groups which are experimental arms looking at abemaciclib, which is a CDK4/6 inhibitor, looking at CC115 targeting the mTOR pathway, looking at drugs like neratinib that targets the EGFR pathway. So what we do here is we look at the genotyping of the patients, and based on the biomarker subgroup that they have, they get particular therapies. So for example, if someone has an alteration in the CDK pathway, they get abemaciclib. Someone who has an EGFR alteration can be randomized to neratinib. And here we are informing, this is again an adaptive design where the model adapts based on the progression-free survival. And abemaciclib is actually being presented at SNO 2020. So please stay tuned for the results. Moving on, gene fusions are potential therapeutic targets in glioblastoma. We do know that gene fusions can drive development in around 15% of cancer patients. And we know this is a sole driver of more than 1% of the cancer patients. So how have these gene fusions occur in glioblastoma? There was seminal work done by Dr. Antonio Veron's group, which led to a science publication showing that FGFR3 TAC3 gene fusion occurs in around 3% of glioblastoma patients. And there are drugs actually that can actively target this gene fusion. We also know that further gene fusions exist in the EGFR, where there's a EGFR CEP14 gene fusion. More recently, there have been the NTRK gene fusions, ROS and MET gene fusions that has been described. Why is this exciting? Because we have therapies that actually can target these gene fusions. So larotrectinib is a highly active drug against NTRK gene fusion and has been looked at and has been approved for those tumors that target or have these NTRK gene fusions. This is again waterfall plot, and as you can see, if the bars are going up, that means the tumors are increasing. If bars are going in a lower direction or downward direction, that means the tumors are shrinking. And as you can see in this very busy slide, that patients with number of different cancers were treated with larotrectinib on the study, including salivary cancer, or where this is very common, gene fusion, lung cancer, colon cancer, melanoma. What is of interest to us in CNS is that high-grade gliomas, both in pediatric as well as in adults, can harbor NTRK gene fusions, and they can be responses when is seen with this drug. When they looked at this study that actually led to the approval of this drug, there was an 80% response rate which was highly impressive in all the tumor types. So this was tumor agnostic approval for larotrectinib for any tumor that harbors NTRK gene fusion. Obviously, we are interested in what's going on in CNS. And as you know, that we have drugs that have limited efficacy, especially in recurrent CNS tumors. So larotrectinib in this 14 patients who had primary CNS tumors showed a very interesting and impressive response rates of 36%. Two patients had complete responses. There were 3 who had partial responses, and stable disease was seen in a number of patients. This is a different look at the patients who actually got larotrectinib. And again, on the left side, we have this waterfall curves. Again, if you have bars going down or going in the downward direction, that means tumors are shrinking. So we are actually getting complete responses, which is obviously very heartening to see as a neuromedical oncologist. And on the right, we have summer plot curves showing the treatment durations. Larotrectinib is a fairly well-tolerated treatment, hence patients can be on this treatment for months and months and years. And as you can see, a number of patients who had either astrocytoma, glioblastomal tumors, even glioblastoma, got benefit from this therapy. So this is again a drug in the armamentarium for neuro-oncologists, medical oncologists, and physicians taking care of patients with gliomas who harbor this NTRK gene fusion. Are there other drugs? Yes, entrectinib is another drug that targets not only the NTRK gene fusion, but it also targets the ROS1. And here you can see some data in brain metastases. As I said before, NTRK gene fusions tend to occur in lung cancer, melanoma, breast cancer. And we know these tumors often go to the brain and result in brain metastases. And when we have looked at the data with both larotrectinib and entrectinib, we are seeing response rates in the ballpark of 50 to 60% with these drugs. So it's very heartening again of these therapeutic options which are available for us physicians taking care of these patients, not only with CNS tumors, but also brain metastases. So selinexor is first-in-class oral selective inhibitor of nuclear export. Why is this important? Exportin-1 is a major nuclear exporter, and increased XPO1 or exportin-1 activates tumor suppressor genes by mislocalization. Hence, selinexor was tested in a multi-arm study looking at escalating doses of selinexor, and 30 patients were treated with the maximum tolerated dose of 80 milligrams per meter square once a week. And here is the data that has been presented in recent ASCO meetings last year, showing overall survivals of around 9.5 months. But what was very interesting with this drug was the tail. We saw around 20 to 25% of our patients got a very durable benefit with this modality. Hence, there's a phase 1-2 fairly large trial testing selinexor in multi-arm study in phase 2 of approximately 350 patients, where arm A will be unmethylated patients who will get radiation compared to radiation plus selinexor. Arm B will be those who have methylated tumors. They will get radiation plus temozolomide in both the arms, but with selinexor in the experimental arm. And then the same trial is actually comparing selinexor in combination with lomustine, comparing it to lomustine in patients in first relapse of recurrent glioblastoma. What are the further challenges in glioblastoma? And what have we done in the last decade or two? So EGFR is a target that can be dysregulated in around 50% of patients with glioblastoma. In around 25% of these, we know there's an extracellular domain truncation that leads to the constitutive activation in the EGFR V3 variant. And there will be a number of drugs, either tyrosine kinase inhibitors, monoclonal antibodies, vaccines targeting EGFR V3, or even antibody drug conjugates that have been explored or evaluated in patients who harbor the EGFR dysregulations. Unfortunately, all of these trials have been negative. However, despite this, there is still a lot of interest in this pathway, which is 40 to 50% of patients with glioblastoma. So there are ongoing efforts looking at nanotechnology ways to deliver these therapies, looking at CAR T cells, looking at BiTEs, BATs, newer ADCs, which may be more efficacious and have less toxicities compared to the ABT-414, the first generation ADCs, or using monoclonal antibodies, but using intraarterial infusions to see if we can improve the outcomes of our patients in ongoing trials, both in the upfront setting as well as in the recurrent setting. We know there has been a lot of interest in immunotherapy, and immunotherapy is changing the landscape of treatment options for a number of other cancers like lung cancer, breast cancer, triple-negative breast cancer, head and neck cancers, and a number of other tumors. Unfortunately, in neuro-oncology, our experience has not been as gratifying, although in a rare subset of patients with GBM whose tumors harbor hypermutation phenotype because of germline biallelic mismatch repair deficiency, there can be durable benefit from immune checkpoint inhibition. This was obviously immunotherapy evaluations, 3 large trials looking at both recurrent glioblastoma and upfront. Let me walk you through this busy slide. Checkmate 143 compared nivolumab compared to bevacizumab. Unfortunately, there was no difference in outcomes of these 2 agents in recurrent glioblastoma. Checkmate 498 was a phase 3 trial looking at radiation plus nivolumab, comparing it to temozolomide and radiation in unmethylated MGMT patients. Again, unfortunately, was a negative trial. Checkmate 548 was a phase 3 trial looking at nivolumab plus radiation and temozolomide in methylated patients. And this also failed to meet one of its primary endpoint of progression-free survival. We are awaiting the overall survival benefit. There are multiple challenges to utilization of checkpoint inhibition. We know glioblastoma is one of the most immunosuppressive tumors out there. The Tregs are highly elevated in this despite having low CD4 counts. Myeloid-derived suppressor cells are even 10 to 12 times higher in glioblastoma patients as compared to regular human population. And T cells may be sequestered in the bone marrow and as a result may not be available for utilization in these patients. We had an effort looking at targeting nivolumab but using bevacizumab, where we could use bevacizumab as not only a steroid-sparing agent, but also using the fact that VEGF is an immunosuppressive agent. And this study presented at SNO 2020 showed that there is intriguing benefit with standard doses of bevacizumab along with nivolumab compared to low doses of bevacizumab with nivolumab. However, the trial was of 90 patients and failed to meet its primary endpoint. So multiple other strategies are looking at various strategies to improve on checkpoint inhibition in glioblastoma. These include, again, a busy slide, but these include oncolytic viruses, using other immunotherapy approaches, using vaccines, tyrosine kinase medications, using CAR T cells, and adding monoclonal antibodies like those targeting the VEGF pathway as discussed previously. There are other multiple strategies which are using now radiation, laser interstitial thermal therapy, and surgeries to help to improve outcomes with checkpoint blockade. One study I would like to particularly highlight is this neoadjuvant anti-PD-1 immunotherapy with pembrolizumab, where use of 1 dose of pembrolizumab before surgery led to an improvement in outcomes of patients with glioblastoma. Very intriguing data that was published in Nature Medicine last year, and I would highly encourage you to go and look up this trial. Other strategies are now looking at combinatorial approaches. Dr. Toms talked about TT fields. We actually have TT fields being combined along with checkpoints, along with temozolomide, and intriguing data coming from the group in Florida from Gainesville showing very interesting outcomes in select group of patients. Again, work being presented at SNO 2020. There are efforts that have looked at vaccine targeting survivin, showing data that has been presented at ASCO and SNO in previous years, looking at overall survivals in the ballpark of 2 years. This approach is now leading to a larger trial that will open up in 2021, looking at an approval study from the FDA. There's a lot of interest in targeting dendritic cells. DC vaccine was looking at this. Again, there was a high degree of crossover in this study, but again, very impressive outcomes at 2 years and 3 years with patients treated with this modality. There has been a lot of interest in oncolytic viruses, and this is the work from the Duke group looking at recombinant poliovirus, where again, as we talked about before, there can be a tail, 20% of patients getting durable benefits 2, 3, 4 years out with recurrent glioblastoma. There's obviously a lot of interest in immunotherapy, and there are a number of abstracts that are being presented at SNO 2020, which I would highly encourage you to take a look at it. Also, the phase 3 results of Dabatex-M in the large trial that I shared with you before is being presented by Dr. Andy Lastman, and a number of other very interesting abstracts that I would recommend you to go and look at in the SNO website for 2020 meeting. Obviously, I talked about the immense role that the patient advocacy groups, play in patients who have glioblastoma brain tumors. And American Brain Tumor Association is one such effort which looks at improving patient and caregiver support, looking at strategic partnerships, offering research funding, and increasing patient and education awareness, helping advance the understanding and treatment of brain tumors. It helps patients and their families find clinical trials. There are a number of resources that ABTC has for patients that include educational meetings, webinars, peer-to-peer mentor groups, connecting you with their community and care lines, which are available for helping advance care of our patients with brain tumors.
So we're going to thank you so much. That was great. So we're going to end this program with some questions that have come in. How do you select patients for Regraphenib? And that's one question. We're going to give that to Dr. Ahluwalia. And also the other questions that have come in. There's been really impressive preliminary data for Selexinor. What was your key takeaway? And finally, Regraphenib, it showed a survival benefit with some interesting side effects. How do you actually manage the hand-foot skin reaction?
So, sure, absolutely. So, as we know, we talked about the gene fusions can be driver of the tumors in number of cancers that we treat. And we know NTRK gene fusions are present in patients with gliomas, high-grade gliomas, astrocytomas, as well as glioneuromal tumors. So what we and several of the people across the country are doing, we are genomically profiling our patients using DNA-based efforts or even RNA transcriptome-based efforts. So if a patient has NTRK gene fusion, there is a pan-tumor type approval for larotrectinib. So you can actually treat these patients with a drug like larotrectinib, which is very well tolerated with very minimal side effects. So it's a very interesting option for our patients who harbor this NTRK gene fusion. Then moving on to the second question that was about selinexor. So the KING trial that I showed and discussed earlier, I think the key takeaway for me was the tail, as we have seen in some of the other trials that were presented. So around 20 to 25% of patients got really durable benefit for a long period of time. And as we know, selinexor is now being looked at both in upfront newly diagnosed glioblastoma setting as well as recurrent glioblastoma setting. So it'll be very intriguing to follow up on these very impressive results that we saw in the KING trial. The last question that I was asked was about Regraphenib that actually had shown a survival benefit when compared to lomustine. But as I discussed before, Regraphenib is a multi-kinase inhibitor. So we know with these class of drugs, you can actually have these hand-foot syndromes or hand-foot skin reactions. So we have used a number of approaches. We have our investigator-initiated trial that is open at Cleveland Clinic looking at this drug as well. And what we do is we actually educate the patient even before they start their drug therapy. We tell them to take care of their hands and as well as their feet. We recommend them to have a visit with a podiatrist to make sure they don't have any calluses, get manicure, pedicure to make sure their hands and feet are in the best condition. We tell them, especially in winter months, to protect their hands and feet with moisturizers, wearing socks, and using protection. If some, unfortunately, patients have grade 1 or 2 toxicity, we can always use non-urea-based emollients and skin ointments, or we can use urea-based ointments as well. If someone has a greater toxicity, we can use topical steroids, which really help. We can also use drug holidays or decrease the dose of this drug to help mitigate this hand-foot syndrome or skin reactions. And with these multifaceted approaches, we have seen that our patients are able to tolerate this drug better as we improve outcomes of our patients, having more of these novel therapies that are available for our patients.
Well, thank you so much. Again, it's really exciting to see how much new information is emerging. It's great to see those survival curves being moved to the right. I want to thank our experts, Dr. Steve Toms, Dr. Mami Ahluwalia, and the experts at peerview.com who've put all of this together.
This activity has been jointly provided by Medical Learning Institute Incorporated, the American Brain Tumor Association, and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/CBA860. This activity is supported by educational grants from Bayer Healthcare Pharmaceuticals Incorporated, Karyopharm Therapeutics Incorporated, and Novocure. This accredited CE activity is jointly provided by Medical Learning Institute Incorporated, the American Brain Tumor Association, and PVI, Peerview Institute for Medical Education.